name is Ash Patel. I'm a consultant vascular surgeon at Guy's and St Thomas's NHS Foundation Trust. I'd like to talk to you about a patient who I recently treated with the new Shockwave E8 IVL catheter. This is a 55-year-old insulin-dependent diabetic. You can see from the photo that he has gangrene of his left, second and third toes. In clinic, he had absent foot pulses and I could feel a popliteal pulse. He's had a past history of hypertension and hyperlipidemia. He was a qualified chef at the time, but unable to work due to his gangrene and chronic lymphocytic ischemia. So my plan was a hybrid procedure where he'd have a tibial revascularization, followed by amputation of both of his gangrenous toes. So you can see from this slide that he had normal inflow from his SFA into his popliteal artery, but his outflow, you can see the runoff on the angiogram. He has a very stenosed posterior tibial artery with some further disease of the lateral plantar artery in the foot. So in these cases, I like to use intravascular ultrasound in order to size my IVL catheter most effectively. You can see from the pullback here that the posterior tibial artery has circumferential calcium with some medial non-complex sclerosis. You can see here that the size is approximately 3 millimeters, and therefore I will choose an appropriately sized IVL catheter. So prior to the availability of the E8 catheter, my options here would have been either a POBA or try a high pressure non-compliant balloon. However, these can be quite risky, especially the POBA. There's a high chance of recoil. When using high pressure non-compliant balloons, I worry about acute thrombosis or very severe vascular spasm causing acute thrombosis. So you can see here that I have passed the E8 catheter down the posterior tibial artery and it has tracked very nicely, and I placed it at the lateral plantar artery. You can see I have delivered 3 cycles of intravascular lithotripsy with minimal need for overlap of the actual catheter device, allowing you to treat a large section of the vessel with the cycles. Following this, I have post-dilated the vessel, which now should be much more compliant and amenable to angioplasty with a non-compliant balloon. And here I've used a 3mm by 150mm balloon. Here is the angiogram showing that the flow through the arteries. Interestingly, there was an area of mid-posterior tibial artery which we hadn't treated with intravascular lithotripsy. You can see the angiogram following a simple angioplasty with POBA shows that this vessel area has recoiled significantly. So we're able to use some final cycles from the IVL catheter, which rewrapped very nicely and tracked down the posterior tibial artery. And you can see following one more cycle of that recoil segment, which hadn't been treated previously, this has now opened up with no evidence of recoil. You can also now clearly see here from the intravascular ultrasound pullback that this vessel is now widely patent. The intravascular ultrasound is sitting well within the lumen and is not being constrained by the vessel throughout the posterior tibial artery, which gives me a good indication of that this vessel is now widely open and has not recoiled. What's also really interesting, you can see from these 2 images, these are pre and post IVL of the distal posterior tibial artery. You can see how before the intravascular lithotripsy, the vessel is essentially a lead pipe with very poor compliance. And you can see now how after IVL, this vessel is now pulsating, is widely patent, and is a much more compliant vessel, and that's why it's been amenable to angioplasty. So I'm pleased to report that the patient was discharged after his amputation of his 2 toes with a negative pressure dressing and sealing clinic. His wounds fully healed with second intention, and he is now back to work as a chef, and he's doing very well. This device is very effective at treating multiple tibial vessels. It tracks very nicely and rewraps well. It's very safe and effective in treating patients with multi-level below-the-knee disease, especially this cohort patients with CLTI who do not have many other options.